Hello everyone, welcome, and thank you for joining today's webinar on compliance and enforcement. My name is Liz Hefren-Webb. I'm the Aged Care Quality and Safety Commissioner, and I'll be chairing today's webinar. First, I want to thank the traditional owners of the lands on which we meet today and pay my respects to elders past, present and emerging. I extend that acknowledgement and respect to Aboriginal and Torres Strait Islander people watching today. I'm joining from Ngunnawal country. Joining me on the panel today are Peter Edwards, Executive Director, Compliance and Enforcement, Mel Metz, Deputy Commissioner, Sector Capability and Regulatory Strategy, Paul Heinemann, Acting Executive Director, Risk Intake and Inspectorate, Scott Rumbold, Senior Director, Compliance, Amanda Innes-Brown, Director of Risk Intake and Analysis, and Tim Davies, our Senior Director for Enforcement. Before I start the discussion, I'll just do a quick bit of housekeeping. After we hear from our speakers today, we'll move to a Q&A session, and you can ask questions at any time. Just use the question box via the live Q&A tab, which should be visible on your screen. We also have a short survey for you to complete at the end of today's webinar to provide us with feedback on today's event. Just stay online and a survey will pop up on screen. It's only short and your feedback is important to us, both in determining future topics, but also to understand the value of the topics we'll be discussing today. Today's webinar will be recorded and published on our website in the next couple of days. Everyone who registered for today's session will be sent a link to the recording as soon as it's available. In today's webinar, we'll talk about how the Commission will be supervising providers under the new Aged Care Act. We will talk about how we will monitor compliance risk and when we might use new powers, including use of conditions on registration. We will also discuss the types of situations in which the Commission may consider taking court-based enforcement action under the new Act. At the end of the session, I'll provide a brief update on the provider registration preview, so please stay tuned for that. So let's get started. I'm pleased to now invite Mel to kick off our discussion.
Thanks, Liz. The new Aged Care Act, which takes effect on the 1st of July, will introduce a rights-based framework for aged care, focusing on the rights and needs of older people accessing funded services. The Act outlines the Commission's functions, including safeguarding, engagement and education, and this means protecting the safety and well-being of older people and promoting quality care, and engaging with stakeholders, and this includes educating providers on their responsibilities and working with them to improve care standards. The new aged care regulatory model sets out how the aged care sector will operate when the new Act starts, and this includes more protections to make sure that aged care in Australia is high quality and safe for older people. The regulatory model has been designed to operate flexibly, and this means there will be a range of regulatory responses available to the Commission to prevent and address incidents and risks that may arise. The regulatory tools available to the Commission align with the powers that are available to other Commonwealth regulators under the Regulatory Powers Standard Provisions Act. So as we move towards the 1st of July and the new Act, it's important to ensure that providers understand the Commission's framework for regulation. That is how we will approach regulation under the new Act and regulatory model. And in developing our regulatory strategy, we've integrated recommendations from the Royal Commission into aged care, quality and safety, and adopted modern regulatory principles such as the Australian Government's Regulator Performance Guide and best practice principles. For those not familiar with the best practice guide, it sets expectations for regulator performance and reporting using 3 principles of best practice. These include continuous improvement and building trust, where regulators are expected to continuously improve how they do their work. This means better matching regulatory treatments to the risk so people can trust the system that's regulated. Risk-based and data-driven, where regulators are expected to identify risks, prioritise and respond to them. And in doing so, regulators should minimise the impact of the regulations, but not at the expense of why they are regulating. and collaboration and engagement, where regulators are expected to be open to feedback and be clear with the public on why and how they regulate. So these principles inform our regulatory approach and strategy. We aim to be transparent and work with stakeholders to ensure that we're risk-based, fair, proportionate, and balanced in our approach. We will also monitor our own effectiveness as we focus on outcomes to improve quality care for older people. This approach is demonstrated in the regulatory diamond. You'll see this diagram in a few slides today, but I thought it was important to include it here to help set the scene. The top part of the diamond explains how we publish information about best practice aged care and performance data about the sector to support and incentivise high quality care. And it also explains how we safeguard older people by regulating market entry, conducting regular audits, and supporting them to resolve complaints. The bottom part of the diamond shows how we have eyes on providers all the time through risk surveillance, and that when things go wrong, we adopt a balanced regulatory response through a provider supervision model. This means that we protect older people by engaging with providers to ensure that they remedy the problem, restore trust, and prevent reoccurrence. And in some cases, we take enforcement actions to reinforce the protections. Providers are ultimately responsible for proactively identifying and managing risks to people in their care. And the Commission's role is to respond to those risks through monitoring, engagement, and where needed intervention based on the level of risk and how effectively the provider is managing it. And this is what we mean by a proportionate and intelligence-based regulation. So I'd like to wrap up my section now by reminding you that at the heart of our approach is relational regulation, which means we seek to build trust-based, respectful relationships with providers. And our intervention is not just about rules and consequences, but also includes dialogue, shared understanding, and support. We absolutely recognise that regulation is most effective when there is trust and providers feel they can engage openly, ask questions, and work with us to resolve issues early. While we will act decisively when that's needed, we also want providers to see the Commission as a partner in delivering safe, high-quality aged care, not just as a compliance body. And I will now hand over to Peter, who will explain what this should look like for providers in practice.
Thanks, Mel, for that excellent summary. A good starting point when we talk about compliance and enforcement is to ground the discussion in what the Commission wants to see from providers. From conversations we have had, and I've personally had with a range of providers across the sector, I get a sense that some think that when the Commission detects non-compliance, it automatically results in a regulatory consequence. And that's why we thought it would be useful to start by getting Mel to give you a bit of a helicopter view of our regulatory intent. Although all forms of non-compliance are of concern to us, our primary objective is to create an environment in which providers are suitably incentivised and equipped to actively work to meet their obligations, and when they fall short, we want them to be equally committed in investing in fixing those compliance issues. And that's why the Commission directs a substantial amount of time and effort towards education and guidance to equip providers to assure themselves they are meeting their obligations. We also want providers to be able to assure us that they have a suitable plan to fix the compliance issue where we detect it, as well as being able to assure us when that plan has been fully implemented. Therefore, the word of the day, if you remember nothing else from this webinar, is assurance, as it's ultimately a failure to give the Commission adequate assurance from which all other regulatory action tends to flow. And that's because, with the exception of immediate and severe risk that requires safeguarding measures to be imposed as quickly as possible, providers do tend to get a window of opportunity to demonstrate their willingness and ability to mitigate compliance risks we detect. The size of that window of opportunity will obviously depend on the level of risk the non-compliance poses to the people receiving care. It's only where a provider squanders that opportunity or has a history of making promises to us they don't keep that we need to resort to using our compliance powers to compel action on the threat of a consequence. And that moves the provider towards the bottom of the regulatory diamond that Mel discussed just before. To put that another way, when we resort to using our powers, what we are doing is just forcing a provider to do what they are otherwise required to do under the Act, standards or rules, or face the risk of a sanction for continuing to ignore their obligations. Therefore, my advice, if you're a provider, is to short-circuit the process by giving us the assurance we need up front about what you're doing to address the issues, thereby saving yourself a lot of time and trouble, and most importantly, doing what is necessary to deliver safe, high-quality services by complying with all of your obligations. Now, it's worth mentioning at this point, there is another reason a provider should use the opportunities they are given to address any failure to comply with their obligations before the risks that poses lead to harm. And that's because it's the best way for a provider to avoid becoming the subject of investigation by our enforcement area under the Code of Conduct, and after 1 July for a breach of condition of registration. In both those cases, there will be court-imposed consequences associated with those breaches. That's something that Tim Davies, our Senior Director of the enforcement team, will talk about towards the end of the webinar. I'll now hand over to Amanda Innes-Brown, who is our Director of Risk Intake and Assessment. Amanda will provide a brief recap on the different levels of supervision we use to manage compliance risk and how providers might end up on the radar of her team. Thank you, and I'll see you shortly for questions.
Thanks, Peter. As my title suggests, I lead a team that supports the Commission to analyse risk and make decisions about how the Commission will intervene through the use of what we call our supervision model. I'll briefly describe the supervision levels. However, if you want more information, you can find that in the Commission's 24 to 25 regulatory strategy. In summary, there are 4 supervision levels: risk surveillance, targeted supervision, active supervision, and heightened supervision. We assign these based on our assessment of how closely we consider a provider needs to be supervised. As our concerns about the level of risk a provider is displaying increase, so does our level of engagement and oversight of that provider, with heightened supervision involving the closest case management and monitoring. Through this, we ensure the right interventions are happening at the right time to ensure risks to people receiving care are being reduced, and where that isn't happening, using our regulatory powers to compel providers to take required safeguarding action, impose sanctions if needed, and as a very last resort, revoke a provider's approved provider status or registration from 1 July. There are various ways a provider will come to our attention for closer supervision, and they can be grouped into 2 pathways. The first pathway is in response to an escalated issue, and the second is through our analysis of intelligence and information that we hold in relation to a provider. A familiar example of the first pathway is when issues are identified through routine audit against the quality standards. Post 1 July, these audits will continue under the strengthened quality standards, supporting provider level registration and re-registration decisions. In addition to that, we also respond to risks escalated where there's been a serious incident reported that requires follow-up, or the serious incident team is uncomfortable with the level of assurance a provider's given us about the controls they've put in place to prevent the incident happening again. Similarly, my team also receives referrals from our complaints area when information from a complaint highlights a potential systemic failure by the provider, or they fail to reassure the Commission that they're taking their obligations seriously. As mentioned earlier, the other pathway is through our proactive identification of risk through analysis of information we hold about a provider. All providers by default are always under the first level of supervision, which is risk surveillance. We hold a large volume of information and data about providers. In addition to complaints and serious incident data, we also hold information about a provider's financial situation, reports from audit and monitoring activities, data on attainment of RN and care minutes targets, as well as changes to key personnel and immunisation rates. We analyse all that information to identify patterns that indicate that a provider, relative to other providers, is displaying risks that warrant closer supervision. We also use our data to inform decisions about the providers we select for activities in relation to specific obligations. Some recent campaign activities have been in relation to infection control, food and dining experience, and compliance with workforce responsibilities, along with a range of other targeted activities focused on prudential compliance. Regardless of how a provider comes to the attention of my team, what we'll do next will always be based on our assessment of the risk we consider the confirmed non-compliance or suspicion of non-compliance may pose to people receiving care and services. Where we decide action needs to be taken, there are generally two ways we seek to obtain the assurance we need from a provider. The first being targeted supervision via what we're now calling our inspectorate function, and the other being active or heightened supervision undertaken by our compliance team. I'll hand over now to Paul, our Group's Executive Director, to discuss the work of the Inspectorate. How a provider responds to oversight from the Inspectorate where there's lower risk non-compliance will often inform what happens next and the powers we use. Over to you, Paul.
Thank you, Amanda, and thank you again to everyone for joining us here today. Now, the Inspectorate receives referrals from our risk intake and analysis area, as Amanda mentioned. Now, this is where a decision has been made that a compliance risk can be managed through targeted supervision. Now, those referrals can be in relation to individual providers as well as groups of providers where there are concerns about compliance with a particular set of obligations. Now, regardless of how a provider has ended up under supervision of the Inspectorate, our objective in all cases is to use our desk-based or our site-based monitoring powers to solicit the information that we need to understand the level of risk, and then to gain the assurance, as assurance being that key word, that the provider has put in place the necessary controls to mitigate the risk. And that is through compliance with their obligations. Now, within the Inspectorate, there are teams that are focused on compliance with safety and quality obligations, as well as financial viability, prudential and governance compliance. We are also currently building a team that will be focused on the targeted monitoring of workers, which will complement the work of other teams in the Commission in managing worker conduct. And for providers that are listening in, it's important to know that when you come under the supervision of the Inspectorate, it's your opportunity to demonstrate to the Commission as quickly as possible your commitment to meeting your obligations. And where you can do that and give us the evidence and assurance that we need that shows you have rectified the compliance issue, our interaction with you will hopefully be short. However, where there are promises made that are not kept, or a provider fails to give us the assurance we need that they have a suitable plan to mitigate the risks of which we are concerned, the intensity of our supervision and the types of powers used will increase. And Scott will touch on that shortly. Now, as Amanda mentioned, one of the ways we detect compliance risk is through routine audit. For that reason, I'll take a moment now to talk about how the Inspectorate interacts with the audit function after 1 July. So where non-conformance is established in an audit activity, you are most likely to be subject to follow-up supervision through the Inspectorate. That's because, based on our experience under the current Act and the existing audit program, most non-compliance we identify through audit is fortunately not at the high-risk end of the spectrum. Therefore, where a finding of non-conformance is made as part of the audit process, despite the opportunities the new audit process will give providers to remediate identified issues before the finding needs to be made, those providers will come under the supervision of the inspectorate until we are satisfied that the non-conformance has been addressed. Now, to support that work, and where a provider is found to be not conforming with the strengthened standards and requires supervision by either the inspectorate or the compliance area, the provider will have a condition placed on their registration. Now, an example of the types of condition the Commission may apply is one which requires the provider to report back to the Commission, demonstrating their compliance within a set time frame. And where we consider it necessary to put such a condition in place, the period a provider is given to report back and the regularity of that reporting will depend on the level of risk. So, for example, higher risk non-conformance may require the provider to report regularly to the Commission for a period in a manner that aligns with the compliance team's oversight of risk through fortnightly case management discussions. Now, we consider this approach to be important, as a provider's ability to address non-conformance within agreed timeframes is an important indicator of both their commitment and their capability to meet their obligations, which in turn informs the registration decisions that we make. Now, I'll hand over to Scott, who will discuss what happens when his area gets involved.
Thanks, Paul, and hello to everybody online today. I'm currently the Senior Director that looks after the Commission's compliance team. My team gets involved where there's evidence of high risk non-compliance or where previous attempts by other areas of the Commission to get a provider to comply have not been effective. An example of the latter situation is where the inspectorate is engaging with the provider, but is unable to get the assurance it needs within the agreed timeframes to reduce the risk posed to people who depend on those services. In these situations, the provider will either move to active or heightened supervision, which increases the intensity of our engagement and case management of the provider. Case management is a key part of the Commission's proportionate regulatory approach. It allows us to tailor our engagement with these providers based on the level of risk and their willingness and ability to respond. For providers under active or heightened supervision, case management ensures that our actions are coordinated, timely, and proportionate to the seriousness of the issues that we need the provider to address. In high-risk matters, we may need the provider to undertake daily meetings with us so we can obtain evidence to verify the actions that the provider is taking, effective actions to mitigate the risks to older people. At times, we may coordinate our oversight of the provider with the inspectorate, who may undertake targeted on-site monitoring to obtain additional evidence to support our ongoing assessment of risk. When a provider is placed under active or heightened supervision, consideration is given to whether we need to use our formal powers to compel action on the threat of a consequence. As Peter mentioned in his introduction, this is almost certain in situations where we identify severe and immediate risk. In those cases, little opportunity is given to a provider to demonstrate their capacity to remediate, as our primary concern is making sure that safeguard measures are implemented as quickly as possible to protect people from harm. That usually involves us using a power to direct a provider to bring in additional expertise to support them to overcome internal capability gaps that have led to consumers being exposed to an unacceptable level of risk. Under the new Act, there will be a suite of new powers that we can use to compel and direct action that have a different consequence attached. Some of these powers that can be used by the compliance team and other parts of the Commission include required action notices, compliance notices, enforceable undertakings, and revocation of registration. The use of these powers will usually be in situations where a provider has allowed people they care for to be exposed to significant risk, or they have failed to use the opportunity that they have been given to make the required changes in a timely manner. Even when we use these powers, it remains our genuine hope that we do not need to resort to imposing the consequences attached to those powers. A consequence is only imposed in the cases where a provider continues to not comply with their legislated obligations. These obligations have been developed to protect the rights, safety, health, and welfare of older people. We take a very dim view of providers who continue to disregard their obligations, especially after they've been on notice to do so. Where that happens, it does lead us to question the provider's suitability to provide aged care. In a small number of these cases, we have revoked the approved provider status, which after 1 July will become a revocation of a provider's registration. Look, this all sounds pretty serious, and it is, because we want providers to take their obligations seriously to make sure that they are delivering the very best care to older people. If you do end up under targeted, active or heightened supervision, I can reassure you that you'll be met with a group of people that are very willing to work with you and help you overcome your compliance issues. It is important that you are willing to work with us by keeping your commitments you make to mitigate the identified compliance risks. The compliance team will engage with you honestly and allow you the opportunity to challenge positions that we have reached. It is important to note that regulation is not about winning or losing, but ensuring the right outcome is achieved, which in every case is protecting the rights, interests and welfare of older people. I'll now hand over to Tim, who will talk about the potential consequences under the current and the new Act where harm is caused and there is evidence that arose out of a provider's failure to take their obligations seriously.
Thanks, Scott. I welcome the opportunity to speak on this topic today. Whilst my team investigates workers and responsible persons under the Code of Conduct, I will confine what I discuss today to our investigation of providers. And that's important, as I want to ensure providers understand the implications currently for them under the Code of Conduct and how our investigatory interest will expand when the new Aged Care Act is implemented. Most of what's been discussed so far, and indeed the majority of what we do as a commission, is what we like to refer to our forward-looking work, specifically ensuring providers are suitably incentivised through our regulatory functions to self-assure when they are found non-compliant, remediate the non-compliance as quickly as possible. This is effectively the risk and trust lens, considering the extent to which a provider poses an ongoing risk to older people and the extent to which the Commission trusts the provider to manage that risk through their response and to ensure they comply with their obligations. This is the assurance the Commission is seeking. I make that point because in contrast to the forward-looking compliance activities that have been described so far, the enforcement team looks back at the events leading up to significant incidents to determine if the incident resulted from substandard practice or conduct amounting to a contravention of the Code of Conduct. The rearview mirror examination is about harm and consequences. We will look at the harm caused or the likelihood of significant harm being caused and determine if there has been a serious deviation from basic safe practice or negligent indifference to provider responsibilities, and whether there should be a consequence to the conduct or poor quality of care. Importantly, where a significant incident occurs post 1 July, the enforcement team remit will expand to include investigations to determine if the incident was also the result of a breach of a condition of registration or a failure of statutory duty. As you will be aware by now, conditions of registration will cover a wide set of obligations, including compliance with the Code of Conduct and the quality standards, amongst many others. The enforcement team will investigate non-compliance with the relevant conditions. In both these cases, where we determine a provider is in breach of the Code of Conduct and or post 1 July a condition of registration, the Commission may decide to commence civil penalty proceedings. This type of action, which is about holding providers and workers accountable for their conduct, is important. The community expects that where a provider allows a foreseeable incident to occur that resulted from substandard practices and or a breach of a condition of registration, they should be held accountable for that. These actions are also important in deterring others from engaging in similar practices. Providers can avoid finding themselves in these situations by ensuring they actively invest in self-assurance activities to identify emerging risks they need to control, as well as taking the opportunities the Commission provides through the Inspectorate and compliance teams to work with us on mitigating risks that have the potential to lead to harm. That's because when we investigate a matter, our appetite for consequential action is heightened when we find a provider was aware of certain risks or should have been aware of those risks, yet took no steps to manage them. Also, where a provider has failed to engage properly and appropriately with the Commission to remedy identified risks. That's why providers need to take their governance obligations seriously. as effective governance that works to detect and treat risks is the best means of ensuring obligations are met and older people are getting safe, quality care. In addition, it's worth being very clear that whilst providers are required to comply with the Code of Conduct, they must also ensure their staff and responsible persons comply with it. A significant focus of our investigations will be on the extent to which there may have been failures in relation to governance, supervision, training, and support for your workforce. Thanks for your time. I'll now hand back to Liz.
Thanks very much to all our speakers. We'll now move to the Q&A part of the webinar, and I can see that we've got a number of questions that have come through already. So I'm going to ask Peter, Mel, Amanda, Paul, Scott and Tim to join me in answering some questions. So I might start with Peter. What are some examples of conditions that can be placed on a provider's registration when there are areas of serious non-compliance?
Thanks, Liz. That's a good question, and it goes to the point that Paul made earlier, which is the way we're foreseeing the use of conditions, particularly where we have come across or detected significant non-compliance, is to align the condition with what with our case management of the provider, such as putting in place a condition to report to the Commission and provide evidence to the Commission at particular junctures. So, and depending on the level of risk, the intensity of that reporting will change. So, for example, if we've got a provider under heightened supervision, we may have quite intense reporting requirements because we want the provider to be working closely with us and giving us visibility of issues that may suggest that the risks are getting worse. But hopefully, in most cases, where our goal is, particularly in working with providers, that we can sort of improve that situation and reduce the risk to people receiving care.
Thanks so much, Peter. Might Amanda ask the next one to you. Will providers know what surveillance or supervision level they have been assigned? And if not, why wouldn't we disclose this?
Thanks, Liz. As mentioned earlier, all providers are under risk surveillance as normal. So we probably wouldn't write you to tell you that. That's just our normal operating position. Where we're escalating our levels of supervision, as Scott and Tim have described, we will be in close contact with you to tell you why we're interested in engaging with you and what we expect you to take, the actions you need to take in response. So whilst you won't receive a letter stating, you'll be very aware of the level of supervision you're under.
Thank you, Amanda. Next question asks, how will the Commission truly know the risk when they have never visited the provider? I might ask Paul to address this one.
Yeah, thanks, Liz. Where we've got evidence that leads the Commission to believe there is risk of non-compliance, as mentioned, one of our inspectorate monitoring responses is to undertake risk-based monitoring activity, which includes assessment at the sites of a provider, which helps us obviously gather the intelligence we need to quantify the level of risk and design the appropriate response, and also the key word, seek assurance from the provider that they are managing that risk appropriately. So engagement and site-based monitoring is part of our approach in terms of quantifying the level of risk and ultimately ensuring that older Australians are safeguarded. Thanks, Liz.
Thank you. I've got a question. What are the consequences when and if an organisation fails to comply with regulations? So that's something we've been talking about throughout, but I might again ask Peter is there a way you could sort of summarise the different consequences?
Yeah, so I suppose one of the key changes when we move to the new Act is that there'll be a range of potential financial consequences. So that will range from infringement notices through to civil penalties. Probably most in the sector are familiar with sanctions around, cutting subsidies to for new residents when it's in the residential space. But as Mel mentioned at the outset, we're aligning our regulatory model to the how other regulators, the tools other regulators have and the consequences they have. So probably the main change is those financial consequences where there's a breach.
Thanks, Peter. I might ask Scott this question. Does the Inspectorate or any department at the Commission provide any supports to help providers address non-compliance?
Yeah, thanks, Liz. Thanks for the question, Liz. Yes, we do. I guess especially from speaking behalf of the compliance or the case management team, we play a significant role, I guess, working alongside providers where we see non-compliance and understanding who they are as a provider and some of the challenges that they face, and also if they require certain supports. The Commission has a range of areas within, like the clinical unit, even the incident reporting area, that we can link them up with educational programs and provide support to providers where we can help them uplift their capability. We also have contacts outside of the Commission with the department and other key stakeholders that we can link providers in to support them, increase their capability and give them every opportunity to comply.
Thank you, Scott. I've got another question here. I might ask you again, Scott. What could be an example of a high-risk non-compliance?
Good question. So I guess off the cuff, my team focuses with that high risk or severe risk non-compliance. So it matters. I guess the main concerns is around clinical care. Like there's some of the highest risk matters that we, does trigger a response from the Commission where we see people, at risk of poor clinical or personal care, and indicators in and around that. So examples would be, where we see, pressure injuries, falls, weights, all types of clinical matters where we see people in pain or at risk of pain and injury. They are, I guess, the higher types of risk that we see. We do focus on a whole range of matters, though. It doesn't just have to be clinical or personal care, but we do take all obligations seriously. And we do, as I said, even coming back to the last question, we do have supports in place where we do see those things and we can support providers to understand their obligations, but also support them on their way to be compliant.
Thanks so much, Scott. Just looking at the questions, is provider compliance or non-compliance made public? I'm not sure. Maybe Peter, you might be best placed to answer that one.
Depends. Well, so currently non-compliance through the audit process, there is publicly available and information about that, and I suppose that's the difference between a finding of non-compliance versus, or in the future finding of non-conformance versus a suspicion. So some of the things that Paul talked about, where we suspect through our data analysis that there is non-compliance, we will be engaging with the provider. We might be talking about the risks, but we may not get to the point of needing to make a formal finding of non-compliance because the provider may address the underlying issue. So there's no reason to do that because ultimately what we're seeking to do is ensure risks associated with that non-compliance is remediated. So the answer is yes and no, depending on whether we have to formally make a finding of non-compliance. Thanks
so much, Peter. I've got a question maybe from Mel. Given some providers may still carry over non-compliance from existing standards, how will they adapt, comply, and manage their risks as we transition to the strengthened quality standards? Will their assessment be based on the current requirements, or will they be evaluated against the new standards after July 2025?
Thanks, Liz. That's a good question, how all the transitional arrangements will work. After 1 July, we'll be assessing everything against the strengthened quality standards. But if we do some of that backwards looking work and something has occurred prior to the 1st of July, we can't use the new standards to measure that. We will use old requirements and obligations. So there will be a transitional period where if we're looking back at incidents that occurred before the 1st of July, we'll be looking at what was in place at the time. But from 1 July, we look forward to all of the new obligations and standards, if that makes sense.
Thanks so much, Mel. I've got a question around court orders. So perhaps for Tim or Peter, can you explain the reference to court orders in more detail? Is this in reference to enforceable undertakings?
Peter, I'm happy to take a dig at that. So, court orders can occur in many different ways. It can be if we take an application for civil penalty, the court may make an order of a pecuniary penalty in relation to non-compliance or breaches that are brought before the court. In terms of enforceable undertakings, they're an agreement between the Commission and the provider. If that agreement is not upheld appropriately, we may seek a court to make an order to ensure that agreement is upheld. Peter, did you want to add anything further to that?
No. I think the key message is that under the new Act there are a broader number of ways a provider may be subject to a court-imposed penalty, and how you might end up before the federal court. But I think the key point in just sort of addressing any sort of alarm about that is that our intention is to only use those powers quite sparingly, and only where we think there has been significant harm has arisen, or where we form the view that people receiving care have been unnecessarily exposed to significant risk that would have otherwise led to harm. So it is something that we will be using, prudently and sparingly, but nonetheless, I think a very important measure to sort of improve accountability across the sector when foreseeable risk is allowed to turn into harm.
Thanks, Peter. And I might just add that the civil penalties are in the new Act. So, and it's got information in there about the penalty units, etc. So this is legislation that was passed by the Parliament, which we will be implementing. So I've been asked, and this might be for Paul, I think, when would the inspectorate conduct site visits? Would it be when a non-compliance is reported, or would we see this embedded into future audits?
Thanks, Liz. Just to be clear, that the inspectorate function is separate from the audit function. So audits are a routine activity that will be required under the new Act as part of registration and registration renewal processes. The inspectorate will undertake site-based activity, as mentioned, where we have escalated risk that we're concerned about, and we need to either quantify the level of risk and ensure the safeguarding of older Australians in care. So we will visit sites, but it is risk response, not directly related to audit. That's answered the question. Thanks, Liz.
Thank you. This is an interesting one. I'm not really sure who to direct it to, but I'm going to ask it and ask one of you to try and have a go. Would a non-compliance notice affect the entire organisation or that particular service? So that's a question of provider versus service.
Look, I'll have a stab at it, Liz, and Mel from a policy perspective might have something else to add. The answer is depends. There are certain obligations that cut across everything the provider does, such as your prudential obligations and management of RADs, refundable accommodation deposits, and then there are going to be notices that we issue because of discrete concerns we have, perhaps if we're talking about residential at a service level. So, our use of notices will be tailored to where the issue is and the extent of the issue. Certainly, when we're talking about obligations around governance, it would always be at the provider level, because it's going to be governance is obviously central to a provider being able to manage risk. So that's probably so I'm sorry I can't give you a precise answer, but it depends on the nature of the risk that we're seeking to manage at the particular time. I don't know whether Mel had anything else to add to that from a broader policy perspective.
I think that's exactly right, Peter. Like it really depends. Is the issue something that impacts the provider at the whole of operation level, or is it something that impacts at just the service level? And I think that will be the determining sort of factor for us.
Thank you. I might just ask Mel if you wouldn't mind talking about the CHSP social day centres and groups and where they fit in the new model in regard to compliance. Are they subject to the same processes?
Yeah, thanks, Liz. So providers are going to be deemed into categories based on the services that they're delivering at the time, and they'll have responsibilities that they have to meet under the legislation, and will regulate based on the provider's ability to meet the obligations that apply to those categories. So we'll take a risk-based and proportionate approach, and the level of engagement will be in proportion to the level of uncontrolled risk or non-compliance.
Thank you very much. I might ask Peter, what kind of priority is number one for us when it comes to compliance risk in the home care setting?
Excellent question, Liz. And I would say governance. And the reason for that is that the nature of home care and support at home in the future is that you're delivering services where in many people's homes with a workforce that's not immediately visible to you. So the lack of good governance controls often leads to risks not being detected or not being detected in a timely manner, and risks not being treated adequately. So, and of course, some of those risks are amplified, Liz, when a provider is also using a third party to deliver services. As I say to providers in this space, when you contract out, you're contracting out your control, not your responsibility. So therefore, you need even more robust governance to manage those relationships and ensure that your obligations are being met if you're doing it via a third party. And so in our Q2 sector report in this financial year, we identified that when we do visits and engagement with providers, we're finding that the current standard 8 governance is often where providers are falling down, partly because many providers have grown quite rapidly, and so their governance controls haven't grown at the same rate as a met growing demand, but also around communication with consumers is the other area. And when you put those two together, it creates a bit of a problematic picture, because having an easy way for people you're delivering services to be able to communicate with you and raise concerns and issues is obviously a pretty important control that needs to be oversighted by your governance to be able to make sure you're detecting risks in a timely manner. So, as I said at the outset, governance should be a priority, particularly if you're a home care provider or soon to be support at home provider that has grown rapidly, and reviewing those systems and controls will be fairly important for you.
Thank you. I might ask Paul, these are a couple of questions. One is there timelines for action completion from providers for non-compliance? And the other is, what kind of additional supports might we require people have in place? For example, might we require a nurse advisor?
Yeah, thanks, Liz, and thanks for the question. Look, the time that we expect response is, we talk risk-based proportionate, but it is proportionate to the level of risk. Where there is immediate and severe risk and people, the likelihood of harm is real, we expect you to take immediate action. And as we said before, the intensity of our interaction and engagement with you will be proportionate to the level of risk. So it is all risk-based, and we expect providers to address those matters that will have the most likelihood of impact to consumers immediately, but we expect you to have a plan in place with appropriate timeframes to remediate all non-compliance and mitigate those risks. So we will work with you to ensure that the most severe things are managed as quickly as possible and that everything is managed within a reasonable timeframe.
Thank you. And just the question on, might we require a nurse advisor?
Yes. And again, depending on the context of the problem that we're trying to address, you may require expertise of a nursing advisor. It may be a business advisor when we're talking governance. It could be financial advisors when we're talking compliance with financial standards. We expect providers are drawing in the capabilities and expertise that are required to address the particular problem, and there are a range of supports, as I think have been mentioned, both within the Commission but also through the department and other avenues to provide that expertise to support providers. Thanks, Liz.
Thanks, Paul. Scott, did you want to add to that answer?
Yeah, thanks, Liz. Just touching on both of those things. One is around, I guess, timeframes from a compliance point of view. We've been in the industry a while and we've seen non-compliance. So we sort of have baselines around how quickly we expect providers, in a reasonable timeframe to remediate non-compliance. Sometimes it can be alarm bells where providers try to remediate it too quickly, and that will impact on the sustainability of those changes. So we try to find a good balance between making quick remediation process that is sustainable but also reduce the risk. And also with the appointment of advisors, sometimes where there are systemic failures within an organisation, it's difficult to keep the operations of especially a residential service running. So it is appropriate to have an advisor come in to do a different type of role to support the governance while the service still keeps the service running and providing care to those residents.
Thanks so much, Scott. I might make this the last question. We've got lots of questions, but I think this is probably for Paul again. If there are discrete issues at service level, but the same issues across multiple services, could that result in provider level non-conformance? And can you give guidance as to how many services it would take or what other criteria it would take to create provider non-conformance?
Yeah, a good question. And I think we've spoken earlier that the Commission holds a lot of data about providers and information. So where we're dealing with an issue, we're always looking into the broader profile of a provider to see if we have got signs or concerns that it is not an isolated issue. There's no numerical answer, but it is, again, once we're concerned, we will keep looking into, we're assured. So where we're seeing, systemic problems, we will firstly try to assure through, it might be site-based monitoring, that it is not a systemic issue, but where we're concerned, obviously we'll keep looking until we're assured that the risk is appropriately managed. So there's not a binary answer, it's not a 1, 2 or 3 answer, it's all about our level of assurance, and that really is the level of assurance that you're able to provide the Commission as a provider. Thanks, Liz.
Thanks, Paul, and thanks to everyone for all your answers, and thanks to everyone for your thoughtful questions. That brings us to the end of today's session, but as I mentioned earlier, our colleagues at the Department of Health, Disability and Aged Care have provided some information they wanted us to share with you about the provider registration preview. And that's about deeming, which determines how providers are registered under the new Act, and the preview process currently underway. So just as a reminder, deeming is a point-in-time action when current aged care providers will become registered providers under the new Act, both legally and in government IT systems. This includes grant-funded providers. Deeming will happen automatically when the new Act comes into effect, and there is no fee for providers for this activity to occur. This will have a flow-on effect to the obligations and conditions which may apply to you as a provider. The provider preview stage run by the department is nearly over, and by now you should have had the chance to review your proposed registration details. Providers have until 5 p.m. on the 1st of June Eastern Standard Time to update any details if needed, but you don't need to do anything if the preview details are correct. Between the 2nd and the 30th of June, provider details are fixed and cannot be changed during this time. And then on 1 July, providers will be deemed ready for commencement of the new Act. We just want to encourage you to check team members in your organisation to confirm if the preview email has been received and actioned. And if you haven't received your provider preview information, please reach out to the department at agecareregmodel, all one word, at health.gov.au with any questions. So thank you so much for joining us today, and a reminder, today's webinar will be recorded and published on our website in the next couple of days. Everyone who registered for today's session will be sent a link to the recording as soon as it's available. There are some resources in the resources tab that you can see on your screen that relate to what we've discussed today, both from the department and the Commission. And finally, a reminder that the feedback survey will be on your screen immediately after this, and that a recording of this session will be published online shortly. So until next time, thank you so much for joining us today.